Dear ladies and gentlemen, my name is Claudio Bassetti, past president of the European Sleep Research Society, and I'm here today with Professor Tiina Paunio, welcoming you to this special webinar dedicated to the topic of sleep and health. We have a small change in program. There were 3 lectures scheduled, but unfortunately, Professor Dirk Pevenage will not be with us today. We will therefore concentrate on the topic of sleep and health in general, sleep and mental health. This will be the topic that Professor Paunio will present. I will then present an update on the topic sleep and brain health. And finally, we will have a discussion that Professor Paunio will then coordinate, and hopefully you will get some new insights into this fascinating topic of sleep and health from this 1 hour together. So let me start with one slide about the definition of health. And you are probably aware of the existence of different definitions in medicine. We like to think about health as defined, or as the situation defined by the absence of disease and disability. Now, since actually the 1940s, the WHO has stressed the fact that health should be defined by also the well-being of the population and not only by the absence of disease. And others more recently have suggested that wellness and resilience should be actually included in the definition of health. Now, generally speaking, most authorities and most societies like to go back to the original definition of the WHO, which defined back in 1948. And in essence, the definition remains until today. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease, infirmity. And I would like to add, the WHO insisted in more recent years on whole life, including definition. Now, we have heard about health. What can we say about sleep health? And this will be a very short introduction. And then I would also allude to some attempts to measure and to operationalize the definition. And then I would like to finish this introduction on sleep health with the outlook. So first, let me tell you that it has not been a long time that publications have appeared on the topic of sleep health. This is a recent review, and you see that it has been really in the more recent years that sleep health has become a topic of interest for the medical and the public health arena, and eventually for the policymakers. So it's a recent development. Now, I will not go into the details of the health burden of sleep loss and sleep disorders. This is not, in essence, the topic of our webinar or of our talk. This is a cartoon from the American Academy of Sleep Medicine, summarizing what we all know, that sleep loss, sleep restriction, but also sleep disorders do represent a burden for our health. The risk of cancer is increased, the risk of obesity, the immune system suffers of sleep deprivation, the risk of heart disease, hypertension, stroke are increased, the increased blood pressure I mentioned already, and eventually there is also an increase in death. So there is a burden of sleep, and I should say also circadian disturbances and losses. So this is why it's appropriate to talk about also sleep health. Another type of burden is related to the economic burden. The data are now here presented from a publication, a cross-country comparative analysis that was published a few years ago by RAND Europe. And this was expressed as a percentage of the GDP of a few countries of well-advanced country. And you see that invariably the burden, the economic burden of sleep loss and sleep disorder is very high, ranging from 3% in Japan to 1.5 in Germany and 2.3 in the United States. So sleep loss, sleep disorders are linked with an increased burden in terms of health and in terms of economic consequences. this very large study actually is a meta-analysis, systematic review and meta-analysis of 36 studies, including over 200,000, sorry for the miswriting, it's 200,000 people analyzed in these 36 studies, people ranging from 1 to 100 years. And this meta-analysis looked at data looking at sleep characteristic across the lifespan in different countries. And you see here, in essence, the range of the sleep duration as one parameter that was studied in this systematic review, and the 10% percentile gained from this study, and then the 90% percentile in the recommended range. And I will not go into the details, but the question was, how is sleep in the general population? What can we say about the sleep duration? And what this meta-analysis shows is that 1/4 of the population sleep less than recommended, particularly in this age range. And this may go up to 50% if you look at teenagers. And then if you look at poor sleep as a report of the patient or insomnia, this is still 10-20%. So we do have a high frequency of sleep loss, sleep problems. And this is the third burden of sleep problems: the frequency, the health consequences, and the economic burden. Now, I will not go into the different possible determinants of sleep health. One, as we have just seen, is sleep duration, and there is this analysis published a few years ago that shows that there is a yacht-shaped relationship between sleep duration and all-cause of mortality. So this leads to the question: how do we measure sleep health? And it is thanks to Dr. Bassetti a few years ago, who actually started the research around this topic. And in this paper he published in Sleep, he suggested that to measure sleep and sleep health, one should have a multidimensional approach looking at different variables, determinants. And he actually defined sleep health as measurable characteristics of sleep that are most clearly associated with physical, mental, neurobehavioral well-being. So he came up with these different determinants: the duration, as I showed you, but also the sleep efficiency, the timing of sleep, how the population feel during the day, as alert or not, satisfaction about the sleep, and sleep behavior. Now, this has led then to some studies trying to measure sleep health in determined population and linking the presence of good or bad sleep with a specific outcome. In this study, published in 2019, the scientists of the group of Bassetti looked at a composite sleep health score, looking at the 5 suggested variables: sleep duration, sleep efficiency, timing, early chronotype being favorable rather than late chronotype, regularity of sleep, and satisfaction, self-report of good or very good sleep. The interest of this study was that this was based on self-report on a questionnaire, whereas these parameters were assessed by actigraphy. So this was the specific approach looking at the sleep health score defined by actigraphy and one question. And they looked at a low-income African-American community, 738 subjects. And as anticipated by the hypothesis, the more the patient had a bad score, the lower the sleep health score, the higher the psychological distress and the physical, and the lower the physical function. So this is an example of how these parameters that have been suggested by Bassetti may be studied in specific population, looking not only at questionnaire as originally suggested, but also at surrogate markers of good or bad sleep through actigraphy. Now, recent authors, and I mentioned here Fan from the group of Key, has suggested that if we look at sleep health, one should look not only at sleep duration and timing, and not only at sleepiness or daytime alertness, but also maybe include some question about bad sleep or snoring. This is now the multidimensional approach, which would call sleep disorder sleep health score. And in fact, we know that indeed in the general population, sleepiness is also associated, not only sleep duration, with an increased mortality. This is a systematic review and meta-analysis of 10 studies published 2 years ago. And you see there was a clear relationship between increased sleepiness independent of the underlying cause and increased mortality. So this has led the group around Professor Key to suggest, the consideration of the 5 determinants that I just illustrated to look at the association with relevant outcomes. So this is a self-report derived score looking, as I mentioned before, to timing of sleep, sleep duration, presence or not of insomnia symptoms, presence or not of snoring, and daytime sleepiness. And what this self-reported derived score could be found to be related to was with an increased risk with cardiovascular disease in this very large prospective study from the UK Biobank. So in essence, what I tried to show is that researchers are now developing different sleep scores, sleep health and sleep disorder score. They may anticipate relevant outcome, and the research is ongoing. And this leads to the final slides of this introduction. I think in the last 10, 15 years, sleep health has become a priority. The idea is to use sleep to prevent diseases, to promote disease modification through sleep intervention, and this should be run across the lifetime. There is, however, still a much research to be done to better measure the health economic burden of sleep, the measures of sleep health that one should consider, maybe the use of new technology, actigraphy, wearables, and hearables to associate questionnaire with other measures of sleep health. And obviously, we need more education, awareness about sleep health. And last but not least, when the data are available, we should also work with policy makers and stressing the importance of sleep health as something that we should take care of. Thank you for your attention about this introduction. I would suggest that we keep, as mentioned in my first minute of introduction, the question for the end, and I'm pleased now to hand over to Professor Tiina Paunio, who will say more about herself in a second. She's been Vice President and responsible for education of the ESRS for many years, and she will now dig into the topic sleep and mental health. Please, Tiina.
Thank you very much, Claudio. And hello, everybody. My name is Tiina Paunio. I'm from Finland, professor of psychiatry, and I will share my screen as soon as I get allowed to do that. So my topic today will be to talk to you about sleep and mental health. It looks like, Claudio, you should stop sharing your screen, and I should then start sharing mine. Okay, great, thanks. So, sleep and mental health is, of course, a very important and relevant clinical topic, which only recently has been gathered larger focus on research. And in this short presentation today, I will first describe shortly about the mental disorders and their concepts, then about sleep and mental disorders, and then sleep and mental health, and end with some therapeutic considerations. So there are many aspects we need to consider when we think the relationship of sleep to mental health. So mental disorders, it's very important to understand that they are very common. The most frequent of them are anxiety disorders, insomnia, and major depression. And brain disorders are actually the largest contributor to all-cause morbidity burden in the EU. As Claudio also, Professor Bassetti also emphasized the importance of brain health to the general health of us individuals. And if we now think about, I need to just put this down so that it will not be too disturbing for you. Sorry for that. So mental disorders are classified into different subclasses. But what is noteworthy here is that even though these are grouped So they share similar characteristics, so that, for example, psychosis is observed not only in schizophrenia spectrum disorders, but also in substance use disorders in some cases, or in mood disorders. Or mood symptoms are not only observed in mood disorders, but also in schizoaffective disorder or stress-related disorders. And anxiety disorders are very frequent, actually, in all in all mental disorders. Also, what's typical for mental disorders is that they are frequently comorbid, so that in this particular study from Finland, from Professor Isometsa, in a clinical sample of patients with depressive disorder, only 1/5 of them did not have any other disorder. All the rest had some other type of mental disorder. Also typical for mental disorders is that the disease course is longitudinal, so that the phase of the disorder is important. There are prodromal phases, there are episodes like in major depression, and the diagnosis might change during the course of the disorder. For example, unipolar depression turns into bipolar disorder if there is an episode of mania or hypomania. And then there are multiple diagnoses, as I earlier stated, like, for example, here illustrated with a co-occurrence of social phobia with a depressive episode. So mental disorders are syndromes with overlapping symptoms and multifactorial backgrounds. Now, disturbed sleep in mental disorders is very common. I have here now summarized in the different categories of mental disorders the most important sleep symptoms. However, I will not go through them in detail because that would be, it would be too much for this time of presentation. But just for example, if we now look at the alcohol use disorders, so in acute phase of the disorder or alcohol usage, the alcohol decreases sleep onset latency, while in chronic alcohol use disorder, it increases sleep onset latency, so that the effect of the drug is varies to the phase when it's used and but also to the phase of the disorder. In non-affective psychosis, like schizophrenia, sleep symptoms are very frequent: insomnia, nightmares, and hypersomnia. And they also link to positive symptoms, higher suicidality, and lower quality of life. It's also interesting that behavioral therapies for insomnia and nightmares have shown promising effects on sleep in patients with psychotic disorder or psychotic symptoms. We looked at the prevalence of different types of sleep symptoms, subjective sleep symptoms, in patients with psychosis. So this was a large sample from Finland. Altogether, there were more than 10,000 individuals with psychosis. For this particular study, we selected those with either schizophrenia, schizoaffective disorder, bipolar disorder, or psychotic depression, and compared the presence of different types of sleep symptoms in these patients in the general population. And we found that total sleep time was increased, in particular in schizophrenia. Difficulties initiating sleep was also increased in all these patients groups, but more so to the affective psychosis. And then the fatigue was very frequent or prevalent in psychotic disorders. We also were able to cluster the patients into 3 clusters according to their sleep symptoms, so that the first cluster was a relatively symptom-free cluster, then there was the cluster with insomnia symptoms, and then the cluster with hypersomnia symptoms. So we now hypothesize that sleep symptoms could be one way of distinguishing patients with psychosis. However, patients also might vary in their sleep symptoms in the different phases of the disorder. Sleep symptoms are also very prevalent in mood disorders, so that in patients with depression, virtually all, more than 90%, have either insomnia or hypersomnia. I will then continue here. And then for individuals at risk for bipolar disorder, so those individuals who who have bipolar disorder in their first degree relatives. So even before the disease onset, it's typical to observe irregularity of sleep-wake times, or subjective poor sleep quality is poor. There's disruption in circadian rhythm, and the evening type of chronotype is more prevalent than in the general population. The abnormalities observed in polysomnography are, of course, frequent, and there is problems in sleep continuity, in sleep depth, and then REM sleep pressure is increased in the mood disorders. So that there are some hypotheses that there would be REM sleep dysregulation behind the core symptoms of depression. Okay, I have problems with this now. Then in anxiety disorders, the sleep symptoms are also very frequent. And there is apparently bidirectional relationship between disturbed sleep and anxiety. This is into slight contrast to depression. Okay, there also the opinions of experts vary, but according to our data, in mood disorders, insomnia seems to be preceding depressive episodes and not vice versa if you look at the population level. And then finally, in post-traumatic stress disorder, the very typical sleep symptom is, of course, nightmares. They are repeated and they link in their context to the traumatic experience. And the pathological mechanism behind that phenomenon is thought to be related to impaired fear extinction and hyperarousal. So disturbed sleep is very frequent in mental disorders, and the different types of sleep symptoms, such as those for insomnia, hypersomnia, instability of the sleep-wake rhythm, or nightmares, are very frequent. However, none of them is specific for any particular disorder, and further, the same individual can express different sleep symptoms during different phases of the disorder. If we then continue with sleep and mental health in more general, and think of the different forms of disruption of sleep, then let's first look at the effect of acute sleep deprivation on the mental processes. So acute sleep deprivation in healthy individuals leads to disruption of a variety of psychological processes. These effects are, however, individual and duration dependent. And in this meta-analysis is summarized the data from several studies, but what it shows is that virtually all individuals, after long enough period of not being allowed to sleep, start to experience delusions or auditory hallucinations. The first symptoms related to acute sleep deprivation most typically relate to mood, regulation of mood, so that anxiety and irritability increase after acute sleep deprivation. But as you see, these symptoms are time dependent, and there is also to some extent individual variation in these symptoms. In this study from Finland by Professor Härmä and Porkka-Heiskanen, it was found that during partial sleep deprivation, the cognitive processes as a group collapsed, with individuals who were not allowed to sleep 8 hours per night as usually, but only 4 hours per night. But then if they looked at in more detail of this group of cases who were not allowed to sleep the full 8 hours per night, so there were big differences, and in some individuals the performance truly collapsed, while in others it remained about at the same level. And this was about the cognitive performance. In summary, insomnia, which is then more chronic form of sleep disturbance, and of course relates to also from its origin to psychological processes. So insomnia is a risk for health in general. But if we look at the risk relationships, so it seems that insomnia is by far the most important risk for depressive and anxiety disorders. However, according to meta-analysis, It's also statistically significantly increasing the risk for somatic diseases such as hypertension, diabetes, cardiocerebral vascular events, or cardiovascular disorders, as well as to Alzheimer's disease and alcohol abuse. Then circadian disruption, which means misalignment of an environmental signal with the endogenous circadian rhythm, that is also a risk for health. And of course, circadian disruption can relate to different situations, like such as irregular working hours, so when you're working in shift, or traveling across time zones, jet lag, or social jet lag, or seasonal variations in light. And in general, so shift work is a risk for mental health, and in particular for depressive disorders. In our study in Finnish population, we found that there are genetic factors which influence the individual liability for circadian or for subjective symptoms after shift work. And we found in a genome-wide association study a variation close to melatonin receptor 1A, which determined to some extent how vulnerable an individual was to experience fatigue when he or she was working in shift. At molecular level, it seemed very likely that there were epigenetic mechanisms that were involved. So sleep and mental health in general, so qualitatively or quantitatively insufficient or mistimed sleep leads to fatigue, impaired vigilance, and depressed mood. While chronically insufficient sleep or circadian disruption increases risk for psychiatric diseases and most notably for depressive and anxiety disorders, but also to many other diseases. What is then the mechanisms behind this co-occurrence of sleep disturbance and mental diseases is not totally clear. It is so possible that it's the disturbed sleep that leads to deviations in mental functions and to mental disorders. On the other hand, there are also examples where mental disorder leads to problems in sleep, or then the third possibility is that there are causative factors that are shared, so that then the same factors express themselves as disturbed sleep in the night and then as mental disorder during the daytime. So, and the data for all these, there exists data for all these three different possibilities. However, most data is for this first alternative, which is that disturbed sleep leads to disturbed mental processes. Now, in the end, I would like to make some therapeutic considerations. First, treatment of sleep and mental disorders. So the role of the thumb is that one should treat the sleep disorder with evidence-based treatment protocol for that disorder. And this is, to some extent, controversial what is done currently in psychiatry. Currently in psychiatry, we think that if you treat the basic mental disorder, then the problems in sleep resolve by themselves. But this is not necessarily true in all cases. And in minimum, a clinician should be aware to follow the symptoms of sleep in his or her patient. And if they remain, then to treat the sleep disorder behind. For insomnia, the treatment for choice is, of course, CBTI, but also medication is used and can be used if there is a medical doctor to follow that. For nightmares, there is imagery rehearsal therapy, and for disturbed diurnal rhythm, there are many experimental therapies such as interpersonal and social rhythm therapy, or recently published protocol to advance the sleep-wake timing for clade chronotypes. And then recently, there are also nice studies showing how treatments using light in a seasonal affective disorder or bipolar disorder can be advantage for patients' mental health. Here is an example of a study from Sweden where they showed that that if you treated comorbid insomnia and unipolar depression by CBTI, that's the effect of that was better than if you treated for CBT D or CBT for depression, so that the symptoms of insomnia were clearly less at follow-up for those patients who obtained CBT-I as compared to those who obtained CBT-D, while the difference in the depression symptoms was not as significant, although there was also there a trend that the CBT-I was better in this group, in this study, in these patients from Sweden. Then in another study, in bipolar disorder, where these patients were not on with current mood episode, and they were randomized to CBT-I and to psychoeducation, it was clear that the CBT-I group showed less mood symptoms and fewer relapses into mania or hypomania at follow-up. So it was effective to treat the comorbid sleep problem within these patients with bipolar disorder. And then finally, just showing this study I already earlier referred to, an experimental study in the night owls who were randomized into two groups, and in which the intervention, which was targeted light exposure, fixed meal times, caffeine intake, and exercise, how this treatment was effective to advance their sleep-wake timings, and also showed significant improvements in symptoms of depression as compared to the group which we did not get this specific treatment protocol. Finally, mentioning the effect of medication, which is very, very complicated, but absolutely needs to be taken into account in clinical work. So again, rule of thumb is that medication of mental disorder can induce sleep symptoms as side effects. Sometimes these effects can be even wanted. The sedating effect of an antipsychotic can be something that the clinician wants. Insomnia nightmares, for example, can be triggered by activating antidepressants, such as inhibitors of serotonin, noradrenaline, or dopamine reuptake. Or sleepiness during the daytime is very typical for many antipsychotics, in particular clozapine or olanzapine or quetiapine, as well as to some antidepressants. On the other hand, these antidepressants can then be used to treat insomnia in the patient with, for example, depression. So to conclude, it's clear that sleep traits could help to dissect mental disorders into etiologically more uniform entities, or alternatively, there could exist transdiagnostic systems across the different mental disorders. But regardless of the etiology, sleep and circadian rhythms need to be monitored and disturbances treated accordingly. And there is absolutely the need to find new treatment protocols, which would be then tailored to individual needs of the patients. So I will hereby want to finish my presentation. Thank you for your attention, and forward this floor to Professor Bassetti. So please.
Thank you, Professor Paunio, for this very nice lecture on the topic of sleep and mental health, which is, as you mentioned, somewhat new, but has already plenty of evidence to support also your conclusions. Now, I have the task to talk about a topic that is not really yet well established in the literature, so I have a little bit more difficult task of presenting a very new field, but it's also a pleasure because I'm convinced that this area has a great future. So let me talk first, when we have to address the topic of sleep and brain health, about brain health in general, then a few words about sleep and brain health, and then what the future should bring and what we should do in the coming years. So first, the brain health, and I start again with the WHO definition, which actually suggested to consider brain health as an approach in which the optimal brain development, including cognitive health and well-being, is included or is implied for all, for the entire population. And again, a point that I made before, not only for a specific age range, but across the life course. Now, what the definition of the WHO also stresses is the fact that this is a person-centered approach focused on promotion, prevention, and not only, as we tend to do in medicine, focus on treatment, care, and rehabilitation of brain and neurological disorders. Now, let me tell you that this year is a fundamental year for neurological disorders and brain health in general, because for the first time, this is a decision that was taken on May 27 by the World Health Assembly. Neurological disorders and brain health have been recognized as a public health priority. For the first time, there is a fundamental decision to consider epilepsy, which was the entry zone, if you wanted, to WHO to talk about neurological disorder, and beyond epilepsy, other neurological disorder are important and needs to be addressed by the different nations in their public health policies. So let me explain a few words about brain health and the strategy. So the first one is about the definition. Now, I mentioned that the WHO has proposed a few years ago its definition. I would like to tell you that there are still some debates about the best way to define brain health. This is a recent paper that I was contributing to with Al-Bofazi Avan as first author, in which the different definitions is presented. In essence, most of them are similar, in which it is stressed the fact that biomedical factors, but also political factors, let's think about the war in the Ukraine, does have an impact on brain health and mental health, social factors, psychological factors, economic factors, environmental factors do have an impact on brain health. And this not only, let's say, in the aging brain, in the aging population, but before birth, in the early childhood, and obviously also in the last phases of death. Let's think about, for instance, the education that you may receive or not in early years. This has an impact on the development of your brain and eventually on your brain health. Now, why is brain health become an important public health priority? Why the largest neurological society in Europe, the European Academy of Neurology, which has served until recently as president, has decided to develop a strategy for brain health? Well, for different reasons. First, it has been shown by systematic studies that brain disorders, neurological disorders, represent a very high and increasing burden. Second, and this is why we are talking about brain health and then eventually sleep and brain health, because there is an insufficient awareness about neurological disorders and brain health. Finally, this is why the Assembly has adopted the intersectorial global action plan on epilepsy and neurological disorder, because most countries in Europe, and we don't talk about extra-European countries, do not have dedicated policy for neurological disorders, brain health, and budgets. And finally, you're probably aware that as for psychiatric disorders, also for neurological disorders, there is a sufferance of patients, caregivers related to stigma and discrimination. And on the other hand, there is much that can be done to decrease the burden. Brain disorders, neurological disorders can be prevented. And the current estimation is that up to 25% of the phenomenon epilepsy, up to 40% of stroke, up to 40% of dementia can be prevented. We have a great development of the treatment options for brain disorders, neurological disorders, stroke, multiple sclerosis, migraine, sleep can be better treated, and we can also rehabilitate. This is taken from our review paper, and this gives you an idea of what we know today about the burden of brain and neurological disorders. 1/3 of the general population suffers of a neurological disease. Not all of them are severe diseases, but they can be disabling: headache, migraine, sleep, stroke, multiple sclerosis. Some of them are devastating. And in fact, neurological disorders are an important cause, number 2 worldwide, number 3 in Europe, of disability-adjusted life years, and third cause in Europe, second cause worldwide of death are to be related or are related to neurological disorders. And finally, if you look at the annual cost of non-communicable diseases, this is an old study. The European Academy of Neurology has started a new systematic studies in 47 countries in Europe. You see the neurological disorders represent a higher burden economically than cardiovascular, cancer, or diabetes. And in fact, as I mentioned, many neurological disorders we start having evidence can be prevented. This is a very nice paper that has been published just recently from the Lancet Commission on Dementia Prevention, Intervention and Care. And along with the definition of WHO that brain health can be promoted throughout the life course, early in life, for instance, with better education, later in midlife, with correction of hearing loss, avoiding traumatic brain injury, etc. And in later life, when you have to control for physical activity, air pollution, diabetes, well, eventually if you have, and this is an estimation not shown yet by data, if you address all these modifiable risk factors, up to 40% of dementias are preventable today. So, in fact, the knowledge about what can be done to, promote your brain health and actually prevent neurological disorders, the evidence is increasing. And this is a cartoon which shows well-established and also some potential determinants of brain health. So, if we go from inside the brain, there are things, behaviors that preserve your brain health. Think about social contacts. This has been shown in the COVID pandemic, physical activity, healthy food, mental activity, and good and enough and regular sleep. Then you have things that you can do to protect your brain and prevent neurological disorders, control cholesterol, normal blood pressure, treating hearing impairment. This may reduce the risk of dementia, avoiding smoking, adaptive coping, treating hypertension, normal weight, treating cataracts, very important also for cognitive decline, treat depression, avoid excessive alcohol, are all things that are good for your brain. And finally, there are things that may not much depend on the single action of doctors or patients. And this, what is the society, the policymakers, the money givers should plan or do to promote brain health. And this is social policy. You have a national plan for neurological disorders or not. You have the air quality, biomedical research, is it good or bad in a given area of the world, political decisions, economic situation, education, and environment. And here I mention again Corona. So this is what we know today about brain health and what we can do and what we should do. Now let's think about what has sleep to do with brain health. Well, this is a lecture in itself. You have heard already something from Professor Paunio. We have several behaviors that, are influenced by normal sleep that we link with the brain. Attention is promoted by good sleep and is actually decreased by bad sleep. Learning and memory, the judgment, motor learning, creativity are influenced by normal sleep and normal brain functions. And as you know, there are different theories about how sleep may promote a normal brain functioning and eventually a good brain health. System consolidation, memory consolidation, synaptic homeostasis, metabolic clearance, energy conservation, and other mechanisms, which I don't have the time to go into, are thought to be creating the link between normal sleep, enough sleep, and normal brain health and normal brain functioning. Now, what can we say about sleep and brain and neurological disorder? Well, let me stress the fact that Professor Paunio, a psychiatrist, and myself as a neurologist are here today is because there is unfortunately still insufficient attention by, I would say, general physicians, policymakers, money givers about the importance of sleep and brain and psychiatric and neurological disorders. Many years ago, or a few years ago, I should say, we have written this review article with the title Neurology and Psychiatry, Waking Up to Opportunity of Sleep, State-of-the-Art and Clinical Research Priorities for the Next Decade. So in essence, if one look now at neurological disorders, since this is my topic, I would like to say that we have now today increasing evidence suggesting that sleep, wake, and circadian disturbance are risk factors for neurological disorders, so they can be a target to prevent neurological disorders, but they are also modulators once you have a neurological disorders of the course of these disorders and eventually also of the outcome. Now, this is taken from the ESRS sleep medicine textbook, which was cited also by Professor Paunio. And this is a summary slide showing you, and the text then gives you the references to support this statement, this data presented in the table. We do have now probably links between certain sleep-wake traits and sleep-wake disturbances and neurological disorders. Excessive daytime sleepiness and a long sleep duration trait are probable risk factors for stroke, and they are now being discussed as possible risk factors for Alzheimer's disease, cognitive decline, and Parkinson's disease. Insomnia is now being considered by most a probable risk factor for the development of Alzheimer's disease and possibly also for stroke. Sleep disorder breathing, this was shown in a recent statement. I will come back to this, of a paper produced by 4 different societies, now being considered a most probable independent risk factor for stroke, and it is now discussed also for Alzheimer's disease, vascular dementia, and Parkinson's disease. Restless leg syndrome and periodic limb movements are discussed as possible risk factor for stroke. REM sleep behavior disorder are risk factors or early manifestation or both for in Parkinson's disease, dementia of Lewy body, and multiple system atrophy. And circadian disturbances are discussed as probable risk factor for Alzheimer's disease, Parkinson's disease, and they are discussed, shift works and long work hours, as risk factors of stroke without having the final evidence for this correlation. Now, I will not go into the fascinating and increasing number of papers linking sleep loss, sleep deprivation, experimentally, but also clinically, and amyloid accumulation and risk of dementia. I refer to this very nice review paper in Nature, showing the situation when you have a regular sleep-wake cycle and normal sleep duration, normal sleep undisturbed, and the preserved clearance, wash out of toxic proteins that are accumulated during the day. So there is this mechanism of washing out these proteins that decrease the burden of amyloid accumulation and possibly also other proteins, including tau. And here, the situation of sleep loss, sleep deprivation, which leads to a decrease in this detoxifying mechanism related to sleep, which then leads to accumulation of toxic proteins, and then an increase, neurodegeneration. And in fact, if you deprive animals and human beings, you do have not only a decrease in clearance of toxic proteins, but also you have an increase in synaptic activity, and therefore also the accumulation of the toxic proteins is increased. Now, I mentioned that as another example, obstructive sleep apnea can be considered today as an independent risk factor for stroke. This is a statement paper I mentioned of these 4 societies: the European Academy, European Respiratory Society, European Stroke Organization, and the European Sleep Research Society. Many sleep disorders and their effect on the risk and outcome of stroke was tested. The stronger evidence was found for obstructive sleep apnea being an independent stroke risk. 37 studies could be found, including 13 treatment or intervention studies, and actually a subsequent meta-analysis confirmed this data. Obstructive sleep apnea doubles the risk of stroke with this relative risk increase, and the evidence that treatment may reduce the risk of stroke is less clear But the conclusion of this statement paper was that CPAP probably or may reduce the risk, particularly if the use of CPAP exceeds for 4 nights per week and 4 hours per night. Now, not only sleep circadian disturbances may be now considered as risk factor for stroke, but we have also the possibility of having an ongoing neurological disorders that may be modulated in its manifestation and its outcome by the presence of neurological of sleep disorder. And this is what this chapter summarizes. Insomnia and sleep loss may be triggers and modulators of migraine, headache, and seizures. You know that you may have more tension headache after a bad night of sleep. Sleep disorder breathing may worsen the outcome of stroke, may increase the number of seizures, the spells of migraine and cluster headache, and circadian disturbances modulate cluster headache, stroke, seizures, and sundowning, the confusional states of Alzheimer's disease at night. Well, let me finish with this paper that we have just recently completed. It's now been submitted for publication, and this actually looks at not a single sleep-wake parameter, but at multiple sleep-wake disturbances. Again, the idea of using sleep health index or sleep burden index. This is a study that we conducted in 437 stroke patients. We performed a regular stroke assessment. We performed a respirography to assess for sleep disorder breathing, and we used then validated sleep-wake questionnaires looking for the presence of restless legs, insomnia, sleepiness, fatigue, and we looked at changes in sleep duration. We created a sleep burden index reflecting the presence or absence of this, sleep disturbances or changes, and we look at the risk in stroke patients for new events, cardiovascular events at 3 years. Well, we looked at patients out of these 437 that had no new events and those that had one or more cardiovascular events down the road after the initial event. And we were not surprised, pleased actually, because this confirmed our hypothesis to see that the higher your sleep burden index was, the higher the risk of new events with the odds ratio of almost around 2 with a range of 1.2 to 2.7. So let me come to a conclusion on the topic of sleep and brain health. Well, I think future research and future clinical care should focus more on this topic, because promoting good sleep will promote an optimal brain health and well-being for all across the life course. And I think more research and more care and more resources should be devoted to the study of sleep-centered approaches, focusing on promotion, prevention, treatment, care, and rehabilitation of brain and neurological diseases. And with this, I would like to conclude my lecture and would like now to hand over to Professor Tiina Paunio for entertaining any questions that you may have. Thank you for your attention.
Thank you so much, Professor Bassetti, for your presentation. So we have a few questions here, and let's see how many of them we can manage with these 5 minutes we still have left. Let's take the first one, and this is to you, Professor Bassetti. Do you think, is there any newer or better tool than Epworth sleepiness scale to measure sleepiness in different sleep disorders?
Well, it is a well-established and a very broadly used scale. So I do think this is probably right now the simplest and better subjective measure of sleepiness. But obviously, sleepiness has different dimensions, and I would like to mention that particularly in neurological disorders, we are more and more looking also at fatigue, which for patients is often seen as something similar. And we have learned that fatigue, which can be measured also with simple scales, such as the fatigue severity scale, is something that you should measure in parallel. So sometimes patients say, I'm tired, I'm fatigued, I'm sleepy, and it is worthwhile looking at both sleepiness and fatigue.
Yes, thank you. Then another question relates to a measurement of sleep. So what would be in your view the pros and cons for measuring sleep at homes with ambulatory polysomnography versus measuring sleep in sleep laboratory conditions? And do they measure the same things? What do you think?
This is obviously a very good question, and very central. And at the end of my short presentation on sleep health, I think that I concluded in saying that we need to use new technologies. I mean, the use of the full polysomnography, I like to say the Rolls-Royce in the hospital is obviously what we should still use for unclear cases. But I think the future of sleep health and sleep medicine is at home in the original and normal environment with the use of wearables, nearables. And I think the key issue is really to show which of these devices is good for which condition. So we need to validate these approaches and to be aware of their limitations. They will never replace the full polysomnography, but for different situations, this may be helpful. This is increasing in the field of neurology and brain health. Maybe Tiina, the question to you, how is about the use of these wearables, nearables in the field of sleep and mental health, sleep and psychiatry? Is this also something that is increasingly being used?
Absolutely, and we could use them in, for example, actigraphy type of measure devices could be used just to see if there starts to become diurnal variation in diurnal rhythm or early symptoms of hypomania, for example, in bipolar disorder, etc. Then another aspect would be to follow up online information about the patient's mental health, to asking direct questions that how do you feel now? Because as we know, if you ask patient's mood or sleep afterwards, it's very imprecise. You should always ask it immediately after the night. One more question. With the latest findings in clock genes, should we look at sleep only as a function of the brain or more as a function of every organ separately and the organism as a whole?
Well, this is also a very good question. I remember I gave a couple of years ago a lecture in front of a very distinguished audience, and I used the slogan "Sleep by the brain, for the brain." And this is a very nice slogan of Professor Hobson, but then I was approached by a basic physiologist who actually told me, you know that we don't sleep only for the brain, and we know that we sleep also through body and brain interactions. So I think you're right. I think we should probably leave the encephalocentric only approach and view of sleep, and I think future should tell us more about the gut and the gut-brain interaction. And I would like to mention also the mental health, psychological, psychosocial context. So I think we should work on a holistic approach, although today we separate it somewhat artificially. I would like to say brain and mental health. I think that Tiina, you would agree that at the end we should work together because it's often kind of related. So I don't know if you want to add something, but at least for the brain and mental health, I think we should not separate too much. But I think it's also good that neurology and psychiatry get involved more in sleep.
Absolutely, and I mean, and of course the whole body is involved, and we have the circadian clocks in the different organs, and they need to be synchronized, and they are synchronized mostly by the brain, but still they need to be synchronized and function in accordance. So I think we have now been this 1 hour through this 1 hour webinar. So from my behalf, I would like to thank you the audience, for your questions and for your attendance.
Well, let me thank you all for being with us. We were short maybe on the discussion part. Let me mention that we still hope that we will catch up with the sleep and body health, because this was also the question, connection and links. And I was very pleased to see that we had over 100 people attending this session. So the response was very good. And I would like to join Tiina in saying goodbye, wishing you a good evening, a good sleep, and care for sleep for your patients. They will improve their brain and mental health through this as well. Thank you very much.
Thank you. Bye-bye.